PA, and I used to teach here. So I'm back, which is really nice. But I've never actually given this lecture before, ever. So after teaching for 10 years, we've actually got a topic that I've never given. So we'll see what happens. But please, if you have any questions, just raise your hand or whatever. I wish I knew our names because I like to pick on people, but you're lucky. I know. So I might like look in your direction, and then, or maybe I'll start pointing. But anyway, if you have any questions, let me know. And I may or may not know the answers, and if I don't, I'll just get back with you. Okay? All right. So I wanted to show you guys this because while I was doing my lecture, I sat down at my in my office, and this is my screensaver that comes up. And do you guys even recognize Coonley? Say, Coonley graduated from this program in May. And he now works with me, which is so fun because I taught him. And so we have lunch together from time to time. And he's doing so well, and he loves his job, and they love him. They love him, love him. So I know you guys are probably overwhelmed right now because this is 8 months in. And there's a lot to get overwhelmed about right now, for sure. So it's nice to see the finish line. He's doing really good. Doesn't he look like a pediatric superhero? I know what I'm doing. And he really does know what he's doing. Like, he feels very confident. It was really hard the first month or two. He's only been working since July, so I guess we're still there. But, you know, getting to know the EMR, and it takes a while for that to become muscle memory, but then he's getting better at that. And I don't know, he's just really situating well, and so it's really good to see. I want you guys to know this is in your future. Also, he's at Variety Care with me, and I wanted to put a plug in for that organization because I wish that I had been exposed to that earlier as a PA. I really wish that I'd been exposed to the whole concept of a federally qualified community health center. They offer so many wonderful things, and the really interdisciplinary approach to taking care of a patient in a way that you just don't get to see that often until you're there. It's completely different. I can't really explain it as well as I'd like to, but if you ever get the chance, or if you're ever rotating there, just take it as much as you can from that experience, because it's a really great, they're really great organizations. I'm really glad they exist. Okay, so we'll just get started. We'll go over the lecture objectives. So, abdominal uterine bleeding is what we'll talk about first, and then we'll build upon it with the Dysmenorrhea and Endometriosis. With abdominal uterine bleeding, these are all the things we'll talk about, and I'll kind of go through them one by one, but I think we'll get around to just about most of them. You'll obviously want to know how to work this up, what kind of exam findings you're looking for, how you take a good history, which is really, really important in AUB, which is what I'll call it from here on out, because I think it's really awkward to say abnormal uterine bleeding. I don't know why. And then now it used to be, and we still do use these words when we talk about what kind of bleeding you can have, like menorrhagia, metrorrhagia, menometrorrhagia. We have all these different words we use, and these are still thrown around. But we try to focus now, or FIGA, which is, there's an International Federation of Obstetricians and Gynecologists, or gynecologists and obstetricians. And they prefer we use FIGA. We use POM-COHN, this is an acronym. And I'll explain why here in a little bit. But we'll talk about imaging, what do we do if this person is pregnant, you always have to rule that out, and how are you going to determine between different types of AUB. Okay, so AUB, I always think of it as the Goldilocks of periods. So a patient comes in and she's complaining because her periods are too long, or they're too heavy, or they happen too often. And that's when you realize, you're like, okay, we have, obviously from the very beginning, we have AUB, right? So it's not a diagnosis. You don't get to stop there, right? We have to figure out what's causing it. But I always think it's a Goldilocks period. We got to figure this out now. It's very, very common. 1/3 of people come in, of women, to gynecologists, all their visits are AUB, just because it's very common. And it can happen chronically. It can happen one time. It can happen one time, no big deal, or it can happen one time in a very acute setting where there's hemorrhaging. So there's a whole spectrum of ways in which this can present and how serious it is. So let's go and talk about comparing normal versus abnormal when it comes to periods. So normally, a period, and just so you guys know, because I'm talking to men and women here, when I say you, I mean the patient, because I've gotten so used to now, I used to teach all the time, and so I would say student, and now I give these talks to patients, and I'm talking to them as a patient. So if I do that, I'm not trying to like single anybody out. Okay, so normally a period is 24 to 38 days, right? So if it's less than 24 days, you're having them probably too often, and that's frequent uterine bleeding. And if it's more than 38 days, we use the word oligomenorrhea. It's still out there, but they also use infrequent uterine bleeding. That means you're going longer than 38 days, you're not having periods that often. Now, sometimes women will either go between amenorrhea, where they don't have periods, and then cycle between that and oligomenorrhea, where they have them every so often. But any time a woman who previously had periods then goes 6 months without a period, that becomes secondary amenorrhea. Before, if they say never get a period, 16, 17 years old, and they just not having a period, that's primary amenorrhea. It's very common and not usually what we deal with generally in the primary care setting. So normal duration is up to 8 days, and usually for your volume, it's less than 80 milligrams per cycle. That's really actually pretty high. Usually it's less than that, like 50 or so. But not that anybody's measuring that, right? So how are you going to know that? And those are the kinds of questions you're going to have to ask. Usually if they're going through more than a pad an hour, but honestly, heavy menstrual bleeding, HMB, which is what they use, what I'll kind of call it that interchangeably. Anytime they have bleeding that is so heavy that it's keeping them from doing the things they want to do in their life, this is a problem, right? So always consider that you don't necessarily have to reach some magic number that they tell you so many pads per hour, or they bleed through their tampon. And then just, if it's disruptive and they're coming to see you about that, they can't do the things they want to do, it's affecting their quality of life, then that's considered HMB. All right, have they had physiology yet? Okay, so this looks familiar. You guys know this whole table, right? Perfect, that's great. Okay, I put this in because I do love this chart. I feel like if you understand it, then it really helps you communicate these things to patients in a way that they can understand and be able to apply later on. And if they're really interested in knowing these things, not everybody is. But it also helps you just think through things. And I'd much rather think through something than memorize something, because there's just too much to memorize in PA school. So you guys know that you have your follicular phase and your luteal phase, right? And that the estrogen dominates, and by dominates, I mean it is higher there, but it's not like, both estrogen and progesterone are there, but estrogen is much higher in that follicular phase, and that's whenever we're maturing the follicle, and then becoming an egg, and then you have your LH surge. And after that, you have follicle, which then becomes your corpus luteum, and then that eventually dies, and your progesterone drops off, and then you have a period, right? Okay, so I'll refer back to this here in a little bit whenever we talk about reasons for specifically the anovulatory AUB, because that's, or AUBO, which I'll go over in a minute, but because those become an issue then. And then you have to start knowing those things about the cycle will help you kind of suss out what might be going wrong. Intermenstrual bleeding. So you can have patients who have a period, and so they know they get a period every 28 days, 30 days, but then they also have bleeding in between. Sometimes it's called breakthrough bleeding and intermenstrual bleeding. So sometimes it happens pretty regularly, like they know they have a period because it's much heavier, and they'll have it for 5 to 7 days, but then somewhere in the middle of their cycle, they'll have some spotting. And usually it's usually cyclical. It happens every time, 15 days, 14 days in, and it's a little bit of spotting, and that's considered probably, most likely, just because during ovulation, your estrogen drops right after your LH surge, and so they'll get a little bit of spotting, because estrogen keeps you generally from having the spotting. So if that and honestly, it's good to know this, because if a patient can tell you when it is, and you can say, oh, okay, well that's just post-ovulation spotting, it's really no big deal. It's benign, they don't have to worry about it, and it's really not even worth controlling unless it's super heavy, or they just unnerves them to have it, which, I mean, it can happen. But honestly, most of the time, just knowing why it's there is enough for patients. So if you could explain that to them, then they'll probably save you a lot of heartache. And it's usually light, like I'm sure I mentioned that. But. So cyclic premenstrual or postmenstrual, other times it can happen either right before they're about to have their period, they'll have a little bit of spotting, and then they'll have a heavy period. Now usually that's because they don't have enough progesterone. Either their corpus luteum isn't producing enough progesterone, and that happens on a regular basis, and usually that's a defect there. Or it could be, especially if it's happening between the time their period comes, anytime after their period and the next period, then you have to consider that they're having some endometrial hyperplasia, buildup in the endometrium, or endometriosis. If it's acyclic, if it's happening and you don't know when, it can happen anytime, then these are other things to consider. Possibly endometrial cancer. The other one is if it happens specifically after, if it's postcoital bleeding. Then you all know, right, you gotta rule out cervical cancer. Always at that point, think cervical cancer. Now, also postcoital bleeding can be inflammatory due to infections as well. So you're gonna get in there, you're gonna go and do the testing anyway, so go ahead and do your GC chlamydia along with your pap smear. So, AUB. This can be, whenever we go over the mnemonic, usually it separates it into local disease or structural diseases, systemic disease, and then medications. And medications are kind of included all over the place. Something that really bothers me is when something, well, it's this or this. Because then I'm like, no, it was in this. Call them right here, don't try to move it. But they do that a little bit with this, so just try not to get too stressed out about it. Usually with women, the most common cause of AUB is thyroids or polyps. And ovulatory dysfunction, super common. The most common cause is ovulatory dysfunction. And then disorders of hemostasis, which occur with endometriosis. Now we'll go over the AUB classification. It's palm coin. It drives me nuts they say coin. Okay, did you guys know, this is something I learned today, so you're going to learn it too. I always thought when people say acronym and an acronym that somebody was saying the wrong word. Like, there can't be two words, right? But there are, just so you know. This is actually an acronym, and it's an acronym because, this is useless, I'm sorry, but I'm going to do it. But it's an acronym because that P stands for something, A stands for something else, that's an acronym, right? But it becomes an acronym, or an acronym, when you can pronounce that word, palm. We're close to it. We're really close to becoming an acronym here, because you can say palm. And this is the kicker, you no longer know what those things stand for, and you just use that word. Like scuba. Like no one knows what that stands for, do you? Unless you're scuba. See? I know. Scuba.
Wait, is the acronym,
see, there you go.
Is the acronym the same as the mnemonic? I thought that was
it
the
is.
mnemonic.
It is the same as the mnemonic. Oh my gosh. See? It's just all over the place. All kind of like craziness. But anyway, so this is an acronym, folks. Not an acronym. But it's really close. I mean, you could. If you hear people start saying things like palm cohen and they don't know longer what it means, then you know that we've crossed that threshold. But I doubt that's going to happen with this one. I think URL is one. It doesn't matter. Okay. So structural diseases, we have polyps, adenomyosis, leiomyoma, which is fibroids, and malignancy and hyperplasia. You should know you all know what leiomyomas are, right? And are they have their own separate one on fibroids, or? Oh, okay.
We have a bit covered during the uterine neoplasm lecture, but very surface.
Okay, it's real handy having you in here, so I can ask these questions. Okay, all right, perfect. And then your Cohen, or non-structural causes. And these are more systemic disorders like coagulopathies, ovarian dysfunction, endometrial issues, like cytokines that cause your endometriosis, and iatrogenic, which is usually medications. And those are not yet classified. We'll go over that really, we just don't know what those are. We don't know where they will go yet, so we put them there. Polyps. Polyps can be, they can be endocervical or endometrial. They're there in the wall, you see. And we're not, and usually we find them either by ultrasound or sonohistography. So usually we use the word SIS now, which is saline-infused sonography. But so those two are interchangeably. If you see either of those two and you get confused, they're just basically the same thing. And usually patients with polyps, they show up, and it's not really heavy bleeding. These are light bleeding. We think it's more of an inflammatory change, which can sometimes disrupt the hemostasis of the uterine tissue. Adenomyosis, this one's even less understood. We really don't know why adenomyoses cause AUB. And they used to be really hard to diagnose because it was required that you get a histology for those. And that's not terribly helpful because by the time, you don't have it anymore, by the time you've got the histology. So now they've determined that there are some ultrasound findings and some MRI findings that usually go along just with adenomyoses, and so they determined a classification for these. Okay, one thing I wanted to cover before, that just reminded me. When it comes to mnemonics and these things like this, why they decided to go through this whole classification system, it's really important for you guys to learn how to do a differential. And this is one of the ways that you can do that, right? I mean, you have this whole mnemonic that you do this. And part of the thinking was, we don't want people to just say amenorrhea or dysmenorrhea or menorrhagia, things like that. We want you to be thinking bigger to possible diagnoses whenever you're actually talking to these patients. And so knowing this mnemonic or acronym helps you think like this in your mind. As you go through all these classes, I would tell every student, build a differential. Always build a differential. Every time you see a patient, even if you see sore throat, come up with 3 to 4 different things it could be before you walk in the room. Because if you do not have this differential in your mind, you cannot ask the questions you need to ask. So just think this way whenever you're learning these things, know that that's the process in their mind. Whenever you're teaching medicine, it's like chicken or egg, constantly trying to figure out which one. It's good to know about things, the definition and the specific details about every condition, but you also need to be able to have a list in your head constantly to rule it out with history. And we'll kind of go over that process in a little bit. So leiomyomas. Leiomyomas are fibroids. Super common, and they can be completely asymptomatic. There could be any number of women walking around with fibroids and they do not know it, and that is okay. The only time it becomes a problem is if they get very large and become painful, that pressure on other organs, start to have recurrent UTIs or GI problems, or you have a lot of blood loss, because that can happen with fibroids. They're way more common in African American patients, 2 to 3 times more likely actually, and they happen earlier. So Caucasians, usually they present maybe in their 40s, late 30s, and it's earlier. And we think perhaps, and we're not sure, but maybe there's a vitamin D connection, because in the end vitamin D is going to be responsible for like so many things. But we're not sure. But African Americans generally have much worse consequences from having vitamin D deficiencies in general. And so that might be what's causing it. So these are diagnosed either on exam, because I had one last week actually. I was like, this is humongous. You can feel it in your abdomen. They came for something else. I just did an abdominal exam, like, is this bothering you? Because it was like a head of a child, like sitting there in her abdomen. And so you can sometimes feel it on physical exam, many times just on a regular abdominal exam, other times on a pelvic exam. But you can feel them on exam. Ultrasound, a transvaginal ultrasound is usually sufficient for fibroids. And these patients usually have heavy and regular bleeding. It's usually happening, not having intermenstrual bleeding, but at the time of their periods, they're just very, very heavy. Malignancy and hyperplasia, generally it's uncommon, which is great. It's still there though, and so you have to have in your mind, think about those things. And I want you to consider cervical cancer, especially in the age range of those ones, more common at 50. Endometrial cancer is a little bit older, but around the same time. And then they present differently. Like with cervical cancer, the bleeding, postcoital bleeding, and the endometrial kind of more all over the place. It's not terribly regular. Intermenstrual for sure. Coagulopathies, most common is von Willebrand's. That's the one you need to consider all the time. And then of course ITP. ITP kind of Sometimes it does happen regularly enough that that becomes an issue on a regular basis, like a chronic condition, but it's less common that it's chronic, it's more intermittent as a phenomenon itself. But von Willebrand's is chronic, it happens from the time they're very young. If you suspect this, what do you think are some things that would make you suspect that this person has a coagulopathy? Right? What, young?
No, bleeding gums.
Bleeding gums, yes, of course, yeah, right. And then, so those are questions that you'd ask, right? And with coagulopathies, these happen more often, you'll see it in young people. Because, well, generally by the time they're older, we know about this. But in adolescents, they show up, and if they have very, very heavy bleeding when they're a kid, sometimes that's just what you go through whenever you first get your period. But other times this could be a coagulopathy. So always consider that in a young person who has very, very heavy bleeding, especially when they ask the questions about the easy bleeding, the petechiae, and other skin changes. Also it happens whenever they're older, because estrogen tends to protect us against some of these things. It tends to increase your von Willebrand factor a little bit, which is why in pregnancy, actually, von Willebrand factor tends to improve, and so they're actually do a little bit better while they're pregnant. So estrogen, because of estrogen surges. But as you get older and you start to have estrogen waning, then they can have really heavy periods too. And anovulatory, AUB-O. So this is the big one, right? Because it's most common, it's going to have your PCOS. And do they have a separate PCOS? Oh, good. It's because it's so common. I mean, every week somebody comes in and probably have PCOS. There's other reasons why somebody would have irregular bleeding, irregular periods, and those could be that they're just young and they don't have regular periods yet. It's not that uncommon to have several months between periods whenever you first start your period. Or if your estrogen's starting to wane, you're going perimenopausal, and certainly whenever you're lactating, right, because of the prolactin. And pregnancy, let's hope you get a break when you're pregnant at least. With PCOS in young people, just so this is something I did not know, but most of the time you don't label somebody with PCOS whenever they're young, right? Like if they're 15 or 16. Usually you start with a androgenism, because really for 2 years if they have symptoms, then we kind of go into the PCOS, that's what that is. But because of this whole physiologic all over the placeness of their periods at that point, we just don't, anyway. But usually if they have, even if they have high testosterone, they won't always label it that, but they will treat it like that. So you can have thyroid issues, or hypothalamic issues. Obviously, if your anterior pituitary isn't working out like it should, you can have issues. Or you could just go into menopause early, unfortunately. And there are some medications which that can mess up ovulation. We'll talk about those here in a little bit. Endometrial, so AUB-E. These are usually cyclic. It's happening, and it's usually people who are ovulating. So they won't miss periods, I guess is what you'll see. And it's usually a diagnosis of exclusion. I kind of hate those myself. I'd like there to be a way for us to test those. But there really isn't. Even though we know what's probably causing these, we think it's the disruptions in the hemostasis of the endometrial tissue, and we know that it's probably related to endothelin and prostaglandins. There's just no good test for that. So we have to rule out other things first, and then we say, well, congratulations, it's endometrial. And that's about what we have. And iatrogenic, which is due mainly to medications. These are usually your breakthrough bleeding or intermenstrual periods that the patients are usually on some sort of OCPs a lot of times. That's usually the most common cause. And usually it's because they're just not taking it right. Or they're missing it, or they start it and they get worried, or they have side effects and they just don't want to take it anymore. And then they'll have some bleeding. But other things cause it too, like antibiotics and anticonvulsants specifically. cigarette smoking is one that you should mention and talk about with patients because it does make your birth control less effective, and it's not healthy to do while you're on birth control, right? Especially over the age 35. You know, at that point, it's a no-no. You're not going to do it anymore. But usually, somebody who is unwilling to quit smoking because of, like, blood clots, that doesn't scare them. They don't want to get pregnant, that's why they're taking it. So they are more likely to quit smoking for that reason. Like, you really need to quit smoking, or you might get pregnant, even though I'm putting you on this birth control. I'm going to do the best I can, but it's possible. Because it basically just metabolizes, it causes the hepatic metabolism to speed up, and it clears, and it just gives you less protection. IUDs. So IUDs are going to come up quite a bit because they're like, they cause the problem and they solve the problem. So many women will have intermenstrual or just bleeding, breakthrough bleeding for the first 6 months of having an IUD. And it's all about education. If you tell them this is going to happen, they're usually okay with it, but you have to tell them. You're not going to do a procedure on somebody that is really actually not the most fun. And then for them to have this situation afterwards, they get angry and mad and just get it out. Because it's not that pleasant for a few months afterwards. I mean, you kind of have more cramping, things like that. So as long as they know beforehand, they're much more open to accepting those things and just writing it out. But really and truly, after the first 6 months, most women, especially with like Mirena or Loletta now, will not have periods after that. So you just kind of give them a goal because they're super helpful for most of these conditions, honestly. It's really, like I would tell you, that you need to consider that always in these patients. And then systemic agents that interfere with dopamine metabolism. So that's your tricyclic antidepressants, but also some SSRIs, or SSRIs could cause it. It's less common, but it can happen. So always consider that. If they're having issues where they're not ovulating and they're on anything that disrupts the dopamine metabolism, you have to consider that that could be the cause. And anticoagulants. So Coumadin, heparin, and low molecular weight heparin, these obviously can increase your bleeding times, and so your periods could be heavier, and they don't. They interfere with clot formation. And this is one they're like, but really, they're not really eye, because they're really coagulopathies. So it doesn't really matter. Right? You just know that it's there, right? And that you're going to consider that when somebody is bleeding too much. Maybe it's your Coumadin. But it's probably not a good indication to stop it. Okay, and then not yet classified unless they're bleeding, unless they really are bleeding out. So there's a lot of disorders that we don't know where they go yet. We don't know whether it's a structural issue, is it a chemical issue, is it both, like with endometriosis, and then AUB malformations. These are all things we don't understand yet, and so we just throw them here until we can figure out where they go in the end. You don't need to spend a lot of time. Okay, so let's talk about the initial evaluation. So when somebody comes in, you're going to think all these different things, right? Some of these problems are acute, some of them are chronic, and you need them to really get specific about, is it heavy bleeding, is it trace bleeding that happens just from time to time, is it happening always on your periods, are you missing periods? There are a lot of different questions that you need to ask them so you can try to categorize their disease process. Is it painful? A lot of these do not have pain, some of them do. And do you have a family history, right, of any of these things? You can have a family history of fibroids, you can have a family history of coagulopathy, right? And then their meds. On their physical exam. So with PCOS, these are the things obviously. Can you guys think of anything else that would go along with PCOS that I don't have on there? Obesity, hirsutism, acne. Those are the main ones that I see too. Thyroid dysfunction, there's a lot. You guys have they had endocrine? Mm-hmm. I've forgotten like the whole, I was trying to remember that this morning. What is this schedule? And diabetes, bleeding disorders, you guys seem to have a pretty good idea about that. The other one is the hypovolemia, right? Because if the bleeding disorder is really that significant, then we could have signs that this patient is unstable. And then the pelvic exam. Sometimes it's not actually the uterus or the cervix. Sometimes the bleeding is coming from somewhere else. So, and there are times when patients really can't tell you. They just know that it's coming from this general direction. So can you guys think of any questions you would ask to determine that? Because they're like, I'm just bleeding. I'm not sure. Or maybe you just need to ask anyways. Huh?
Are you itching there? Are you scratching?
Oh, true. Yes, you could just, that could be something external, right? And so, yeah.
Like how heavy is it? Is it when you wipe?
Yes.
Or is it in your panties? Or?
Yes, heaviness is a big deal because heavy bleeding generally is uterine and uterine in origin. So if it is just scant bleeding, that is more likely to be something either external or possibly or a hemorrhoid, right? So what are some things you would ask about that? Does it happen with defecation, clearly, right? And then also, does it happen when you have a tampon in? Like, say you've just placed a tampon. Are you still bleeding? So, because the odds are probably you're not, if you've just placed it, probably not going to have uterine bleeding right after placing a tampon. There's a lot of ways that you can ask that question, but the first thing you need to do is make sure it's really coming from the uterus or cervix. And of course, the physical exam will help you, because sometimes you will see it right then. They'll have some spotting. Hopefully not too heavy, because then it becomes a more significant problem. So now you've moved on to your labs. You always, always, always have to do a pregnancy test. Always. One, because if they are pregnant, then we need to focus on other things, and they could have a really significant issue on our hands that needs to be dealt with acutely. But also, the treatment for these would involve a lot of times, right, OCPs or some form of birth control. And so we need to know ahead of time if the patient is pregnant before going forward. Get a CBC. I'd say always get one myself unless you had one a few weeks ago or last month and this has been a chronic condition that hasn't really changed much. Always get a CBC because, right, because we need to make sure they're not anemic, right? So if a person was, would it change anything about your treatment, do you guys think, if the person was anemic? Like, for one thing, obviously, what if it was below? Like, what do you guys think about? What's the significant like hemoglobin? If we're at a hemoglobin, like, we gotta go somewhere else.
8.
Yeah, 7, 8, anything? Okay, so if you're 8 and you're symptomatic, you're going, right? So that's the little difference. 6, no brainer, go. But 8, symptomatic, you're gonna go. So, yeah, so that would be one thing. But what if they're just like a 10 or 11?
Maybe give them some iron.
Yeah, give them some iron. But I think it's good to know this because even though it's not an acute emergency situation, it's still something that you can present to the patient, right? And say, because sometimes patients know they have this and they're really not interested in anything about it. They just want to tell you about it. Other times, that happens a lot actually about lots of different things. But other times you can say, okay, here's the deal. You're obviously anemic. We're going to give you some iron. But I'd kind of like to keep you from getting worse, right? And be able to control your symptoms in some way. So maybe we need to do some birth control. I find this specifically helpful in adolescents whose parents are not wanting them to go on birth control. Because even if you tell them this is, you need to have this and for this reason, and I'm not trying to tell your child that they can go and have sexual intercourse, they just are really hesitant sometimes, to be honest, depending on their own cultural background. And so if you say, okay, here's the deal, they are anemic, and we're going to continue to have this problem and do iron and worry about her passing out every time she has a period, or we could control it. So if you have petechiae or bleeding gums or bruising all over, then first we would go down the line of Littleburn factor, factor VIII, and a thyroid. I usually always get a thyroid, and then gonorrhea, chlamydia, person has risk factors, right? Or especially if it's just trace bleeding, bleeding after postcoital bleeding, or certainly any dyspareunia. Imaging. So usually your first go-to is the transvaginal ultrasound. Generally it will tell you a lot. It will usually tell you what you need to know. Sometimes you can't see some adenomyosis or, and then you'll need to get an SIS or just, and then of course if you're later on, if you're thinking endometrial, you usually get a hysteroscopy. Very rarely do is MRI. It's just not, it's there, it can work. And generally it's more of an incidental thing. We do it for some other reason we find that. But. And then endometrial biopsy. We'll talk about, well, let's do acute versus chronic first, because that's the next slide. Acute. So if the patient comes in, and for also, just so you guys know, most of the time we're talking reproductive, right? Reproductive age, we're not pregnant. That's what we've been discussing most of the time here, right? Okay. if a woman comes in and her blood loss is significant, and we need to do something about it, that's an acute AUB, right? Sometimes it'll be the first time they complain about it, and even if it's just happened a few times, but it's not super emergent that we take care of it, we consider that chronic. So you did the pregnancy test and it turns out she is pregnant. So now what are you thinking? So she has pain with her bleeding. Now what? Ectopic, right? Yes. So you just assume. Okay, we gotta work this up immediately. If you can't get an ultrasound that day, you just send her somewhere where she can get an ultrasound that day. Usually at the very least I'll get in touch with an OB/GYN and let them know and that I'm sending her to them eventually, and I'm getting an ultrasound that afternoon if I can. And I have enough for, like, usually they'll get her in with their person right then to work it out, because not always they want to go to the emergency room, especially if the pain's. So if the pain's really severe, I would just go to the emergency room. Sometimes the pain is just kind of there, and there's a lot of situations like that you'll find in your clinical practice where you're like, oh, it's just not as bad, and you need to be able to work out some fail-safes in that situation so that you know that you're doing what you need to do to meet the standard of care and to protect the patient, but not necessarily go overboard, because they won't always show up to the emergency room. But anyway, always assume ectopic pregnancy at first. It could be a threatened abortion. It could be that they're just having some spotting, implantation spotting. But the transvaginal ultrasound is absolutely is the most important thing to do in that situation where you have bleeding and pregnancy. You can get an HCG to see if this person's having a threatened abortion, and then do another one in 48 hours to see if it's climbing. But the ultrasound is more definitive. Sometimes doing both of them is helpful because you won't always expect. Knowing the range of the HCG is helpful in interpreting the ultrasound ultimately many times. So if you're going to do a transvaginal ultrasound, you're just going to go ahead and get a quantitative HCG. But mainly just so you know how to interpret that ultrasound appropriately if you're going for the transvaginal ultrasound. Sometimes you will just get a quantitative HCG, especially if they're not having pain and they're really early on and you're not in the emergency room. So when do you get imaging? So the lady who I felt last week, she got a transvaginal ultrasound pretty soon afterwards, right? Anytime you feel something, if you see it, you're going to evaluate that by ultrasound. Anytime you've treated them for a while, 2, 3, 6 months, they still come back and they're having symptoms, they haven't improved, you need to go ahead and get an ultrasound. Sometimes we'll talk about getting an ultrasound because we're worried about endometrial cancer. And it's, just so you know, we'll talk about when you do an EMB, I think on the next slide. But if you're thinking, I'll just put off doing an EMB because I think I'm worried about endometrial cancer, but I'm not sure, and I'll get an ultrasound because I need to do that anyways for all the other pathology associated with this. It'll be useful, but it will not rule out endometrial cancer in a woman who's under 35. It's just that that endometrial stripe is just so variable that the likelihood ratio is not predictive. It's not a good way to rule it out. You can't use it. So you can do, if you're worried about a woman who's under 35 and she has risk factors, you can't just skip that EMB. You have to do the endometrial biopsy. And then usually it's a stepwise approach where you do the ultrasound, then the SIS or the hysteroscopy, based on what you see on that ultrasound and where you want to go from there on. So when do you get an endometrial biopsy or an EMB? Any woman over the age of 45 who has AUB is going to get an endometrial biopsy. That's the age where they're at greater risk, and so you just need to go ahead and do it. If any woman of any age who you've treated and they just cannot be not improving, you go ahead and get an EMB. If she's under 45, right when she shows up, and she has any risk factors for endometrial cancer, you go ahead and get an EMB. Now, if you see the risk factors, like obesity, that's just like everyone, right? Like everyone's over 30 in my practice anyway of their BMI. So it really increases the number of EMBs that you order considering this one, and hypertension too. But nulliparity is a big risk factor for endometrial cancer, and of course family history. And polycystic ovarian syndrome. Have they had the PCOS lecture yet? No.
Tomorrow.
Oh, good, okay. But PCOS really increases your risk of endometrial cancer. The endometrial hyperplasia that goes along with it if you don't control periods, or not having periods on a regular basis. And this is an endometrial biopsy. Endometrial biopsies can be done in the office. Not super comfortable, but they can be done in the office pretty easily if you know how to do them, if you're trained how to do them. But I would warn them that there's some cramping and that they might need something afterwards to help with that. Okay, yeah.
Can I ask how many samplings you're taking when you're doing the biopsy?
So you take it and you fill up, you actually just have one thing that you fill up to a certain point. So it's not, you don't go several times, yeah. And then as long as you get usually you'll get at least, that sounds funny, but it looks like a red earthworm that it stays, it just does. It kind of stays congealed and it goes, as long as you get that much, you're good to go. So you might have to get another thing out and try to limit it. And usually they're bleeding, they can be bleeding at the time that's birth. Okay. I love a decision tree. I think decision trees are going to be helpful for you for the rest of your life practicing medicine. Anytime you can find one of these, and honestly, I use UpToDate. This is UpToDate. If you, I would tell anybody to invest in UpToDate as a clinician, have available to you. If your office has it, then that's a great perk because it's really helpful and specific, and they've all been. Usually, they pull all their information from the Cochrane database, which is really good. Okay, this is really small, so I'm going back here. So first you have to determine, is it coming from the uterus? Then once you do determine that, right, because it could be something else, like we mentioned before, it could be the external genitalia or the urethra or the GI tract, obviously it'll go a different direction. Then look at the age, is it pre or postmenopausal? Postmenopausal, it's increasing your risk of endometrial cancer, right? So you're going to go down that track a little faster. And then, is she pregnant? And then this, I feel like this is a great table. This is where everything is that you need to have. Sometimes what I do whenever I'm seeing a patient and I feel like overwhelmed, which is what you will experience on a regular basis for a good year and a half after getting out of here, is just knowing sometimes what labs are really helpful and why I'm doing them to begin with in a table like this. And this is basically a good, just concentrated information of what I've ever covered. So I'm not going to go over all of it right now, but I just want you to know these exist. I'm sure you do already know it. So chronic treatment options. So first you have to know what's causing it, and then you need to know how severe it is, right? Because that's why you need the CBC, so you can determine if we need to treat other things in addition to the AUB. Consider if they're having pain. Consider if this is keeping them from getting pregnant, because that could, obviously if they were desperate to become pregnant, certainly in advancing age, you need to light a fire under it and get started earlier. And do they want to become pregnant? Are they not wanting to become pregnant? Because that will change based on what you do. Maybe they can't be on birth control because they have uncontrolled hypertension, or they have risk factors, or a history of breast cancer, or family history of breast cancer, and they can't be on contraceptions. And then, does this patient, are they willing to go through this process where they go through all these medicines and then go through with surgery later, which is usually what we do. I mean, usually it's medicine first. Or do they want, are they interested in a short-term option, or they need to be done with this? They just have no patience for this, and they need this to be a long-term solution. And there's also, and those things are also really helpful when it comes to compliance too. A patient using OCPs or combined OCPs are great, but if you're not going to be able to take them on a daily basis, then that's not a good option for you, right? And so you need to figure out something that will work for you, usually an IUD or the next one. Okay. after we figure out what it's causing it, right, because we might have other things we need to treat, like possibly we need to treat their PCOS, or we need to treat, and by PCOS, and you'll learn about that tomorrow, I won't go through that, but there's a huge plethora of things that go into the treatment of PCOS. It's a lot of behavioral and diet and all that kind of stuff that goes too, so it's a huge treatment plan. Or infection. You gotta figure those things out first, and then treat those particular etiologies, and then consider, if that's not it, if it's not a hormonal issue, or if it is, in the case of PCOS, we still treat those with OCPs. Consider OCPs or an IUD. Usually we start with, especially if it's heavy menstrual bleeding or ovulatory dysfunction, we start with monophasic. Do monophasic combined oral contraception pills. There's lots of them. Usually if they can handle it, if they're not oral contraception pill naive, and they can take higher doses. Higher doses are more helpful unless they have a counterindication of that. Anything over like 3 is a little more useful in controlling bleeding. But if you can do an IUD, if you can talk them into doing an IUD, it's really very helpful to do an IUD. Because it gives them 3 years of treatment where they don't have to think about this after that first 6 months, to give them that information. And it's not dependent on their compliance. But they might want to become pregnant in a year, and that makes them not a good candidate for an IUD. So there's lots of things for you to consider. And you can use progestin-only contraceptives, but it has to be high dose. You can't use low dose progestin whenever you're treating AUB. You have to do high dose. Okay. Sometimes they come in and they really don't want anything, or it's not that big of a problem yet. Maybe their mom's noticed it, but they really don't care about it, and they don't want to do anything. So that's fine. We can just talk about what options may be available to them whenever they do choose to go down this road. But you do need to check to make sure they're not anemic. So get that CBC and say, that's okay, we'll just monitor you. We'll have you come back every 6 months. We'll talk about how you're feeling now. Is it disrupted to you now? And get a CBC. NSAIDs, we use them quite a bit along with the antifibrolytic agents. They help you break down clots less often. They help so that you're forming clots a little better. NSAIDs block prostaglandins, which help out with the vasodilation, or vasoconstriction rather. They help to cause vasoconstriction. And then hormonal methods, which we talked about. And then for PCOS, consider metformin. Not always, but especially if they're having any kind of insulin resistance, increasing blood sugars, or you see a high insulin level on your lab, consider metformin in those patients. So thyroid dysfunction. Thyroid, we don't really, a lot of things that we don't actually have a good understanding of why this happens. For thyroid dysfunction, we feel like that the TSH works, or thyroid hormone works synergistically with your LH in causing ovulation. And so whenever it's low, when thyroid levels are low, you don't ovulate as often. But usually once we get thyroid levels and they become thyroid, they start to have periods after 2 months. And then hyperprolactinemia, we know exactly why that's happening, right? And we treat the high levels of prolactin, and then get better, usually after 2 months as well. But that's after prolactin levels go down, and not immediately after we start treatment. It takes a while for that to normalize. So hemorrhage. This is whenever somebody's coming in and they have active bleeding and it's very heavy. It's a different situation than somebody just coming in noticing they have heavy periods that are disruptive from time to time. This person, first and foremost, you have to rule out any trauma, any serious coagulopathy, and a pregnancy. And then you may have to order blood. They might have to get a transfusion. Not always necessarily when you do a biopsy, but you will afterwards. And then high dose estrogen is given right then and there. And then you have to give for 3 weeks estrogen, a combined estrogen pill, estrogen and progestin pill. And usually they're heavy doses, so consider that you need to control their nausea, because if you don't, they won't take them. And they could relapse, so just send them out the door with some Zofran. And then you'll give them OCPs for 2 months after that. Surgical options. So a DNC is where they dilate the uterus, dilate the cervix, and then they scrape off the inner lining of the uterus. And this does help most of the time in decreasing the heaviness of the bleed. But it's not a permanent fix. And so you will have reoccurrence usually with a DNC. Unless we solve the problem, unless we figure out this was really due to some other primary condition, and then we figured that out and treated it. It does allow you to get a tissue to get histology, which is nice. And they can get this and still plan to become pregnant in the future, unlike the rest of these. But you can get tissue sampling with an EMB as well that doesn't affect your fertility. So it's not the only reason, it's not like you need to get histology to do a DNC. An EMB is less invasive, it doesn't cause as much pain, and so if you were just looking to get tissue sample, then that's the way you should go. But a DNC can be helpful as far as temporarily helping with the symptoms. Endometrial ablation, we use this in heavy menstrual bleeding, but when the medicine fails, and once they've decided they do not want to have kids. You cannot get pregnant, you should not get pregnant after having endometrial ablation, because you can't build up the endometrial lining the way you should. And much higher risk of miscarriage at that point. And uterine artery embolization, they call it AUE, but they also call it uterine thyroid embolization as well, IFE. And IFE is probably what we do more often now, because they use it, it's specific to the actual leiomyoma. They go in, a radiologist goes in and they insert a chemical that makes that artery clot right there. And so it doesn't feed the fibroid anymore, and it shrinks. But you don't get that whenever you don't do that if you're going to have babies. And hysterectomy. This one is definitive, right? You don't have a uterus anymore. You don't have uterine bleeding. And we usually do it after medicine fails. But people really are happy with their hysterectomies if they have a long enough history of heavy menstrual bleeding. And that's usually key. If they've gone through all these steps and they're still having it, and it's still disruptive, they're going to be really happy when it's done. And we want them to make a really informed decision and not be unhappy later, because this is like forever. All right, so we'll go through all these steps and treatments first. Do you guys want to take a break real fast? Because we're at an hour. Okay, take a break.